Hey everyone, for this video I wanted to touch base on pulmonary hypertension and its effect and role in the ICU. So pH equals pulmonary hypertension. All right, so we define pulmonary hypertension by in two ways as far as the textbook goes, is mean pulmonary arterial pressure, so mean PAP equals greater than 25 millimeters of mercury, okay, at rest. And of course, greater than 30 during exercise or activity. All right, but that doesn't really matter too much for our critically ill patient. There's many reasons to have an increased pulmonary artery pressure, mean pulmonary artery pressure, and it could be because of baseline pulmonary hypertension. It could be because of the etiology of the disease, inflammation, hypoxemia, right ventricular failure, left ventricular failure. So there's many reasons that pulmonary hypertension can manifest in our critically ill patients. So just saying that these pressures really don't mean much to us as far as a diagnostic mechanism. So, but just remember, these are measured by the pulmonary artery catheter or during a right heart cath. Okay, so we'll just leave that there. Okay, just in case you encounter anything as far as establishing a baseline. But the real thing we want to look at pulmonary hypertension is the effect on certain aspects of the circulatory system. So if you look at Ohm's law, okay, so there's many permutations of Ohm's law, but the one we're going to look at is voltage times amps times resistance. Voltage equals amps times resistance, okay? You don't have to remember this. It's just a baseline for how I'm going to explain this. And then volts, okay? All right. So what this can translate to for us as clinicians, where it makes the most sense, would be a change in pressure equals our flow times resistance. All right. So furthermore, that's going to equal our mean pulmonary artery pressure minus our left atrial pressure equals our cardiac output, all right, that's our flow, times our pulmonary vascular resistance, all right, to represent the right side of our heart. Now let's isolate this term here because that's what we care about right now, right? Our mean pulmonary artery pressure. So if we move things around, we'll get our mean pulmonary artery pressure equals our cardiac output times pulmonary vascular resistance plus left atrial pressure. Now, left atrial pressure also means pulmonary capillary wedge pressure, okay, which is also measured with a PAC. All right, but we're just going to use these terms for this presentation. So these are determinants of increases or decreases in your mean pulmonary artery pressure. So, of course, if you increase your cardiac output, your mean pulmonary arterial pressure is going to go up. Increase your PVR, that's going to increase. And increase fluid buildup over on the left side of heart, that's going to increase. But the most important aspect of this equation is right here. And that's our pulmonary vascular resistance. This contributes the most to our right ventricular afterload. Now, with pulmonary hypertension, there's something called pre and post capillary. So pre and post capillary. All right. And all you need to know about this, when we're talking about post capillary, we're talking about the left, right? And we're talking about pre, we're going to talk about the middle to the right. And hopefully that doesn't confuse anymore, but the middle being your pulmonary vasculature and your right being your right side of your heart, post capillary being the left side of your heart, okay? But we're going to focus on our pre-capillary issues because our right heart is not accustomed to pumping against increased pressures. It's not designed for that. It's a flow-based system. There's a little bit of pump to it, but barely anything if you look at the pressures, right? What are our normal pressures? Like 25 over 13, or our right ventricular systolic pressure is like 25 over 4. So that's not really a high pressure system. Um, so our right heart does not like increased afterload. And that's manifested in pulmonary hypertension. Now, this could be a disease process from COPD. It could be a chronic issue, of course, but it can also be inflicted in the ICU via hypoxia, different disease processes that are acute. So pulmonary hypertension can manifest in different ways, but people can definitely develop worsening of this by not taking their pulmonary arterial hypertension meds. But pulmonary arterial hypertension and pulmonary hypertension are two different things, and we're going to get into that this week. So there's different groupings of states of pulmonary hypertension, but for this, we're going to talk about just pulmonary hypertension in the ICU. Let me just put that here. All right. So let's look at the effects that pulmonary hypertension has on the heart. All right. So we already said that the right heart does not like increased afterload. So let's go down the line here. All right. So let's say we have our right heart here. So let's say we have an increase in our right heart afterload. We're just going to do R and then afterload, okay? Just for time. Okay, so if we have an increase in our right ventricular afterload, what does that mean? Well, that means we're going to have a reduced right heart output. All right? And if we reduce our right heart output, well, it has to go through the system to the other side, so that means we're going to have reduced LV preload. All right. And then that also means we're going to have reduced LV cardiac output. Okay. So you can see already how this picture is forming of the dangers of pulmonary arterial hypertension, or pulmonary hypertension, I'm sorry. Thinking ahead here. So what does all this mean actually as well? So there's many other things that are happening within these 4 steps, and we're going to see that in a second. So an increase in right ventricular afterload, this could be because of, not because of, but this can cause, some of these things are pretty obvious. So this can cause RV stretch. And think about when, you have systolic heart failure. I don't know if you guys remember this, but you have your mitral valve, and you'll end up developing some sort of a mitral valve insufficiency or regurg. Well, when our RV stretches out, our tricuspid valve is going to stretch. So we're going to develop some tricuspid regurgitation. Regurg, okay? And that's further going to decrease our right ventricular or right heart output, which would also decrease our LV preload, which will also decrease our LV cardiac output. All right. Let's see here. So with this right ventricular stretch, we're going to talk about something called ventricular interdependence. So ventricular interdependence, if I can write it up here. Come on. Ventricular interdependence. We're just going to say inter-D. Okay. So ventricular interdependence means that, and we're just going to draw pictures here for this because it makes life a lot easier. So if you were to look at the heart from, let's say, the atrium's down, right? So you have your left ventricle here. It'll look a little bit like a circle, and you're going to have your right ventricle here, which will look like a crescent. So if you did like an ultrasound of the heart, so we'll say this is our RV. We'll say this is our LV. Okay. Ventricular interdependence states, or is a notion of how one change of the right ventricle will affect the left ventricle, because they share the same pericardium, they share a septum, they share the same fibers amongst each other. So although that the LV is strong and powerful, changes in states of volume And these two chambers will affect each other. So let's think of this RV stretch here. So if this RV is stretching out and filling up with fluid, blood, we're going to start having a change in the shape here. So what's going to happen is your LV is going to become kind of compromised and turn to this little crescent shape, and our RV is going to stretch, right, and balloon out. So this is a little exaggerated, but it's going to balloon out. And so we're going to have a less filling volume over here, and obviously stagnation here and increased stretch, and then increased regurg, like I said, because of our tricuspid and all that fun stuff. So what is that going to do? So our ventricular interdependence is going to decrease our LV preload, and it's also going to decrease our LV cardiac output. And there's not enough blood going back into it. So we have an increase in RV afterload. What is that going to do? Well, that's going to increase O2 demand. All right, from our right ventricle. And if we can't supply that oxygen, we're going to have RV ischemia. Okay? And you can see where this is going. If we have RV ischemia, we're going to continue to reduce our RV output. And if we reduce RV output, we're going to have a reduction in LV preload. And here's where it gets kind of fishy. So a decrease in LV preload is going to decrease your coronary flow. Right? Because our coronary blood flow supply is dependent on diastolic pressure in our preload. And if we decrease our coronary flow, we're also going to have an effect on our cardiac output. And then we're also going to have an effect on RV ischemia. Okay? There's a lot more that goes into this, but just trying to keep it a little cleaner than it could be. But just understand that this is a very dangerous cyclical event, and we're just going to keep having an increase in oxygen demand, and we're not going to be able to supply the oxygen demand. So there's things that we do that will affect this in these patients, and even if they don't have clinically significant pulmonary hypertension, we're going to increase a patient's right ventricular afterload. So things like, and this is why PEEP is so important, excessive PEEP. All right. Also, not enough PEEP. All right. So what do I mean by not enough PEEP? I mean atelectasis. Okay. And that's going to increase your either thoracic pressures, or it's going to have the alveoli kind of coalesce around the vasculature and create this increase in resistance in your pulmonary vasculature. So too much PEEP, not enough PEEP. And when I mean PEEP, I also mean excessive ventilator pressures. We can have RV stretch over here worsened by fluid administration. All right, fluid administration. And if we have a state of shock, what do we usually do? We usually give fluids. So we can kind of propagate this cycle by giving too much fluid. Conversely, lack of diuresis. We're just going to say lack of pee. Okay? And what I mean by that, let's say you have someone who does take their Lasix every day and they have congestive heart failure. Well, if they stop taking their diuretics, we can have this whole backup here. And that would be a post-capillary issue. Let's see what else will affect this. Just about everything. So hypoxia will increase right ventricular afterload. Let's see. If people stop taking their pulmonary arterial hypertension meds, we're going to have an increase in our right ventricular afterload. So as you can see, this is a whole big cycle of things that we can affect. But what this can manifest as at the end of the day is a cardiogenic shock. Okay? But it's not that simple. cardiogenic shock could occur from all of this stuff happening and getting worse, and you have right ventricular failure, and then we're in trouble, right? But we can also have an obstructive etiology as well, because we have all these things going on, right? And we're talking about what we're doing to the patient. Well, what about a PE? Pulmonary embolism, not physical education. Well, that's going to create an obstructive shock. Okay? So we can kind of have a mix here of obstructive to cardiogenic shock. And if you guys have ever seen massive PEs before and people deteriorate very quickly, it's very scary and very, very fast. And also some things that'll cause increase in pulmonary artery pressure. Oh. So let's say increase in mean pulmonary artery pressure are things like ARDS, COPD. We can also have tension pneumo. We can also have cocaine. I can barely read that. And meth use. Okay, those will increase your pulmonary artery pressures. And then, like I said, we'll have our PEs and obstructive shocks. All right, and you can also have your pulmonary pulmonic valve stenosis, pulm stenosis, and then even your mitral valve stenosis or tricuspid stenosis as well. So valvular disease. Okay, so a lot of things can cause this, but pulmonary hypertension in the ICU is definitely a vicious cycle, and you can see how it occurs here in this middle part right here. So you increase this, you're going to decrease that, and then overall your systemic perfusion is going to suffer, and your right ventricle is going to suffer as well. We can combat this on our side by making sure our ventilator pressures are correct, providing enough FiO2. All right, we'll let that out, FiO2. Being cognizant of their I's and O's. Understanding the physiology of pulmonary hypertension and its effect on the heart. Also, during intubations. So our intubation process will affect all of these outputs as far as right ventricular failure. So if you have someone with a PE that you're going to have to intubate, you're going to have to do it very quickly, for one, and two, you're going to have to understand that the drugs you're going to give this patient are going to affect your cardiac output even more, and then it's going to affect your RV afterload even more. So you have to be very cognizant of that. So if you are the one intubating, you have to make sure that you are positive you're going to get that tube in as quickly as possible. I've been in those situations myself, and it's very scary, but you have to be confident in your skills. But just understand everything we do will affect this, and just understand our vicious cycle right here, okay? And some contributive factors. So we have to be aware of our contribution to this disease process. And we also have to be aware of the physiology, like our ventricular interdependence and our RV stretch. All right? So thanks for watching. I hope this helped you out a little bit as far as understanding pulmonary hypertension in the ICU.